All right. Happy HIE Awareness Month, everyone. I am Betsy Pilon. I'm the Executive Director of Hope for HIE, and I'm thrilled to welcome Dr. Terrie Inder to our Q&A series, our educational series. And today we're going to be talking about MRI, and this is a big one for our families. It is something as a part of especially neonatal HIE. MRI Day is this big sentinel day in the journey when families get a little bit more information about the potential impact, the impact that their child has already experienced, and then talking about what that means potentially for prognosis. And a lot of things happen with MRI, but MRI is really complicated as well. And Dr. Inder, you have been a trailblazer in understanding MRI and neonatology, and in particular with HIE. So I'm just so thrilled to welcome you today. And so for those of you that are joining in, feel free to use the chat. Let us know where you're joining from. And if you're watching this on a recast, you're always welcome to add commentary that we'll review. And if something's applicable to the chat, to the conversation we're having, we will find a way to get that in there. And just a reminder that this is not a place for medical advice, and we're having a conversation about, educating with MRI and HIE today. So Dr. Inder, can you give us a little bit of your background and interest, how you got involved in having this be such a focus area for you and your research and your care?
Yeah, so I'm Terrie Inder. I'm a native New Zealander, hence the odd accent. So I'll try and speak as slowly and clearly as I can. I initially trained in New Zealand in pediatrics and neonatology, and basically through an experience I had with a family friend's baby who had severe PBL, I became interested in the newborn brain. This is going to be the last. And
Having a little bit of a disconnect with
that
technology. What happened? There we go.
Hopefully you have me live.
Yes, there we are.
Have an interest in being able to train in neonatal neurology. And in that neonatal neurology, I was able to train with Dr. Joseph Volpe in Boston Children's in neurology for 3 years. And after I completed that, while I was doing that, I actually became interested in MRI. And it was the very early days of MRI. And it was the very early days that MRI was being applied to newborn brains. And during that time, we were testing it both in preterm babies and full-term babies, and that was in the late 90s. And from then on in, I was both a neonatologist, someone who was trained as a child neurologist, and someone who had a major interest in MRI. But it was a serendipitous journey, because I kind of ended up, being motivated by a family friend's baby, and then getting to know about MRI from another friend I met in Boston when I first landed there. And it wasn't something that I came out from medical school destined and focused on. And as the journey has taken me forward, diffusion imaging was developed during the time I've been in the field. Spectroscopy's been developed while I've been in the field to a greater extent. And then understanding how to apply it during therapeutic hypothermia. I had the privilege, after going back from Boston to New Zealand, to work on the first translation of the animal model into human clinical trial of therapeutic hypothermia, and then to develop another therapeutic hypothermia trial that we rolled out in Australia. So I was fortunate to be on the cutting edge of the application of therapeutic hypothermia. And ever since then, I've been motivated to try and continue the journey of improving outcomes for our babies. And to me, MRI has been a helpful tool to try and understand when and potentially why something happened. It's also, more importantly for me, a tool to guide rehabilitation and where and what we need to be focused on to try and improve outcomes. Because really all of my focus has been on how can we prevent injury if we can, and if we can't prevent injury, how can we help improve long-term outcomes. That's
Yeah.
me.
Wonderful. Thank you so much. And, as families are pouring into to tune into this, MRI is such an integral part of the HIE experience. And so let's talk a little bit about this, a little bit more in depth about the evolution of MRI. And you mentioned a few different things. So if you could also help kind of define, we talk about spectroscopy and other things and what that means for, a parent.
Yeah. So MRI is always a scary thing, I think, because many parents may have had contact with an MRI machine, and they're pretty scary machines. They're very big, they're very loud, they're awful to lie in because they're so claustrophobic, and it's a pretty scary experience. For the babies, they don't experience it like that because hopefully we feed and wrap them and they just go to sleep when they're in the scanner. It's kind of like going for a ride in the car. They get that little bit of motion from white noise and they hopefully just drift off to sleep. And so we've been a leader in trying to make sure all the MRIs are done without any sedation or anesthesia so that the babies can not be put at any additional risk. The good news with MRI, of course, is there's no radiation. What MRI is a big magnet. It's a big magnet that vibrates, and that's why it's so noisy. What it's doing when it vibrates is it's vibrating the molecules in the brain. And that sounds scary too, but they're such tiny, tiny vibrations, they don't do anything to the brain. They just will move either the proton, which is what the standard conventional MRI sequences are, or they will move the water molecule, which is what the diffusion sequences are. And we are then vibrating the molecule, and then we relax for a period of time, and we see how far the molecule moves after the vibration. And based on how far the molecule moves, we can tell what kind of structure the molecule is in. And that then translates to an actual kind of black and white. We call it a voxel. It's a little box in which we are sampling the movement of the molecule. And then that translates and is interpreted into a color on the MRI image of either black, white, grey, and that's what generates the pictures, because we do that for the thousands of boxes that are in that one slice. When we take an MRI scan, therefore, we always want to do anatomy first, because that tells us whether the brain was built normally, and that's important. And so we will do traditional sequences always first. Those are what we call T1, T2. Those are just vibrating the protons. And we do those in multiple different views, which is why MRI generates so many pictures. But we will do them going from the top of the chest, if you like, or the bottom of the neck, all the way up to the top of the head. That's called axial. We do it from the front of the nose to the back of the head. That's called coronal, where we take slices all the way back, and we do it ear to ear. That's called sagittal. And so we will do this for each of the anatomy for both T1 and T2 to look as to whether we see any differences in the way the brain was built, particularly looking at all the different structures inside. And we are interested in all the different areas of the brain. So the brain I often compare to a major computer warehouse. It's like a big, big warehouse that was developed. And on the outside of the warehouse, you've got all the hard drives. They're all the workers that are doing all the work. And that's the cortex, or the cerebral cortical grey matter. Those are hard drives generating thoughts, generating ideas, people working away very hard. But they have to pass all that information somewhere else, because the information's no point if it just stays in that one space. So the way it moves is down a cable in the brain, or it might move down a sort of a system within the warehouse, that information has to move to another part of the brain. And it will move, 80% of the information is going across the warehouse, like it's moving from the first protocol to the next, from vision to interpreting vision to then what that might mean. So it's moving around the warehouse. 20% of the information is going in and out of the warehouse, going down the spine, in and out. And all of the information, whether it's going across the brain or in and out of the brain, goes through the central area in the middle of the warehouse that I think of like the system administrator for the warehouse. That's the deep nuclear grey matter. So the hard drives on the outside, the cortical grey matter, that's the kind of the workers. The cables are so-called white matter. And then in the middle, the system administrators, the deep grey matter. And the system administrator is always busy. Even when you're asleep, even when the warehouse is quiet, they're monitoring the security of the warehouse. They're always busy. And so they're very energy demanding. And so when there's a lack of oxygen or blood flow, the central administrator region is very, very sensitive to being injured and being hurt. And if that's the case, of course, that might be one part of it that's connected to one part of the warehouse, or it might be the whole system administrator, which then makes the rest of the warehouse really have a lot of challenges in terms of operating. Sometimes we see injury where certain areas of the warehouse, for instance, when the lunch cart comes around, the lunch cart spreads out through three main routes, right? The three main blood vessels, anterior, middle, and posterior blood vessels. And the areas that are last to get the blood flow are those areas, or the lunch cart are those areas between the two tracks. And so if the blood pressure drops for some reason, or the lunch cart has not got enough lunch on it, then those areas that lie between the normal supply are going to be the areas that are least likely to get supplied. And that's called watershed, like the watershed between your sprinklers, right? That's called watershed injury. So we are looking for these two key patterns, the pattern of the system administrator, the deep nuclear grey matter, and the injury in the watershed patterns. We look at the T1, T2, but on the early MRI, up until day 4, 5, 6, 7, we're really looking most at the diffusion. And why is that important? Because diffusion is looking at the movement of the whole water molecule. And it's different, right? It's not looking at structure per se. It's looking at kind of a function of whether the water can move or not within the brain. And if the cell is not functioning well, the water can't move. It becomes what we call restricted. And when the water movement is restricted, that tells us either the cell is swollen, very sad, or is dying. After the cell has died, then the water moves freely because it doesn't have any more cell structure to move within. And then we see the diffusion become high rather than restricted or low. So in the first week, we're really looking mainly at that diffusion imaging for the water movement. It's blurry. It's not definitively telling us that it's definitely injury. There can be situations like seizures where you'll see swelling in areas that are under stress that may not be fully injury. Whereas the T1 and the T2, they are most helpful after the first week of life, really getting into the second week of life after about day 14. And they tell us definitively that there is injury because anatomically we see the loss or the injured areas of the brain. And then finally, spectroscopy, which isn't done in all centres, looks at chemical movement in the brain. And that will be telling us about the actual chemical composition of parts. And again, we usually take one box only in the brain, and it might be the deep nuclear grey matter, and we'll be looking for abnormal buildup of acids or loss of the normal chemicals within hard drives. So they are all telling a story together about whether there's injury, when the injury likely occurred, and then what might have the consequences for the pattern of injury.
This is incredibly helpful. I have never heard it broken down in such a wonderfully comprehensive way that is so applicable for families. We get families often that are trying to ask about interpreting their MRI results. They might have gone over it with their team in the NICU, and then as they're processing everything they've been through, they're like, wait a minute, I'm going through this. What do these pieces mean? So I think all the information is just so helpful to have, so families can go back to this and get a better understanding. So thank you for sharing that. And one of the things that I wanted to touch on, because I know in my own experience and when I've talked to, physicians like yourself and others, is realizing that the baby's brain, you mentioned water, and that babies' brains are still fresh, and that the water content actually is much greater than in an adult brain. And that sometimes that can be, like, as MRI has changed over the years, might have been a trickier thing to, wade through in the analysis of what you see on an MRI.
Yeah, I think there's three things that I would emphasize are really important. And it's not because everybody's not trying their best, because they are. But one, we need the baby to be able to lie still in the scanner to get really good pictures. We need the person who's both acquiring the MRI, i.e. they're driving it. They know how to drive it to get the best pictures for babies, because babies' brains are very different to children's brains and to adults' brains. And so the scanner has to be driven a certain way that can make it usable and well applicable for babies. And that's quite different if the place that the baby's imaging is being acquired aren't used to babies. They may not know how to get those best pictures. And then finally, whoever's interpreting, the radiologist who's reading the MRI, is really, really important, because if they're, again, not experienced or used to doing a lot of baby MRIs, then they may not be used to what's normal and what's abnormal, and they may not recognize some of the types of patterns or abnormalities. And so that can be very hard, because a different person looks at it and gives a different result than the person who originally reported it. And then very finally, I'd say, as I've already kind of alluded, the timing of the MRI will make a big difference as to how likely it is the MRI will see the abnormalities. And that can be hard for us, because we often don't know exactly when the injury happened. Only about 10% of the time do we have a very timed event, like an abruption or a uterus that ruptures, or cord prolapses, or a mother collapses, or something very, very known. Many times the babies come out after the fetal heart rate is not reassuring. There might be some meconium. People are a bit worried, so they go to a cesarean section. But we don't know exactly when things went wrong. And so it's hard to know when the clock started as to when things were going wrong. And we know that most people like to be off the hypothermia blanket before they do the MRI. And so that usually means after day 4. But unfortunately, we know if you wait till you're out to day 7, your diffusion has already got a lot less. It's a lot harder. It's maximally low between day 2 and 4 after injury. So if you're going to wait to day 7, you may not see much on the diffusion, and you may not yet see anything on the T1 or T2. So it may be that the MRI is relatively reassuring, that the doctors say to you, well, we didn't see much. Everything's good news. But sadly, the baby is still not yet telling us that by their behavior. And so something doesn't add up, which is why we are huge advocates for repeating the MRI after around day 12 to 14 in any baby where there's any concern that what the MRI early showed and what the baby shows don't agree with each other, one way or another. If the MRI gave a picture on diffusion that was very scary or sad, but the baby now looks really good, you should redo the MRI, because sometimes what you saw was just stressed cells that weren't going to die and they were going to recover. But we can't tell which ones are stressed and which ones are definitely dying earlier on. More likely than not, they're dying, but occasionally, very occasionally, I've seen them completely reverse. and the repeat MRI look completely reassuring. And at least in the latest data we and Mohammed had produced, and also more recently there's a publication, shows at least 20 to 25% of the time between the day 4 and the day 14, the MRIs change.
That's a huge percent. Yeah. And I think that's, we see that a lot with our families trying to make sense of this, who will also say, well, they had an MRI or they said it's mild, and then their child has a greater impact than I think they were originally told. And then vice versa. We have obviously a lot of families that are told, like, don't expect your child to walk and talk and whatever, and have the reverse outcome. So this is really helpful context for our families, for sure, to understand that the timing is really important. And there's so many factors that go into, the physiology, the growth, the timing of the course of injury, and what we can learn so much as they go. I've heard the term pseudonormalization. I had heard that from Daniel Barber. Like, we talk about MRI, and that was a concept that, like, I had never heard that before, until like a year or two ago. And I thought, wow, that makes a whole lot of sense, just from the anecdotal sharing that our families will do with one another, trying to make sense of why an MRI says what it does. And I think, even just backing up, a lot of families, we hang on to every word and try to understand. So when you talk about like severity level and you talk about MRI, I mean, most people, this might be their first, foray into acute care and into having something real serious. And most people know someone that's gone through cancer, right? And so, like, they're thinking about MRI and they're thinking about staging and trying to make sense of how this might apply or not. And I think that's where some of the disconnect happens, because it is something that is very unique, and that, we're learning more all the time about, what this does mean and what it could mean, and what could be, when we talk about a little bit later about research and, new therapeutic development and things that could really help in addition to cooling. But we can also talk about cooling, I'm sure, with your experience of being involved in so many of the early trials, and, kind of what have you seen over the years as we've, have gone through and improved care and implemented hypothermia more.
Yeah, and what I would say is that people do hang their hats on the MRI, but really you want to take the whole picture into account. So you want to know, if your baby, for instance, had seizures, even if the MRI is negative, it was telling you that something in the warehouse was misbehaving, right? And so it's important to see how the baby does. And if there are still some concerns around day 10, we now have a threshold here that if any of our babies are still in the hospital at day 10, they get another MRI. Because we just need, everybody deserves, after everything they've been through, to have the best information they can. And 2 pictures of the brain at different time points are better than 1. And so if they have not got home by day 10 to 12, we are offering another MRI universally now. And we weren't doing that a couple of months ago, because we've just had enough experiences where things have changed. And then I would say that the other thing is that even when the picture does show some significant abnormality, it really depends which region of the brain is affected. For instance, if you take out a third of one side of the warehouse, you may still recover and have literally minimal to no consequences, because the rest of the warehouse reorganizes. The warehouse wasn't set in stone as a baby. That's the great joy about the neonatal brain. It's got a lot of bilateral representation. It had things around the warehouse that adults don't have in terms of backup strategies. And it was ready to try and pick up and carry additional responsibility. And that is the role of rehabilitation. And sometimes people say to me, well, your relationship between some of those MRs and outcomes isn't as strong as other groups. And I'm like, well, that's because we work hard for it not to be the same. We work hard to try and help our babies from the day the MRI is done to be doing rehab from the time they're diagnosed. Because if you were a pediatric patient or a a trauma patient, you would be getting rehab from the day that MRI diagnosed that you had a selective brain injury. Now, they can show us their deficit because they had function and they lost function and people know what they're working with. Our babies can't do that, but that doesn't mean they don't deserve the same advocacy and the same opportunity, because they can reorganize even better and be left with literally minimal to no stigmata from this if we work hard. Now, the problem with that is I've already talked about this central system administrator area that is so central to the whole organization and the reorganization of these areas of the warehouse. And so that's where we really are still limited. If we see significant damage in the deep nuclear grey matter, those are the babies that are hardest for us to try and reorganize things. And for these babies to sometimes function as well as, or show us their function as well as they might be. Like the warehouse workers might be working, they might actually be doing good stuff, but the babies can't show us well what they're doing because they can't get those messages in and out very easily through the administrator. So those kids sometimes have got a lot more opportunity to be doing more than what we can get access to because their motor impairment is so significant. So we've got a lot more work to do in that area and a lot more to move forward and a lot more work to do generally. But I would say cooling does change the evolution of the MRI. Most of us are dealing with mainly all cooled babies now. And so I think people are getting used to that. The peak reduction is still day 2 to 4. And so after day 4, you are still relying on diffusion normalizing. And if anything, the only other thing it does is slow down how long it takes to see the full injury on T1, T2. So that's why we try to wait for as long as possible to get that last MRI. And even if it's hard to wait as a parent, you're going to get more information the longer you can wait to get that. I know there was a question that had been posed about waiting even to like 1 year or 2 years, and whether that is helpful. Of course, any later time point is helpful, but the problem with that is it's too late for the rehab. We know this first year, and in fact, we just had the privilege of writing a commentary for Journal of Pediatrics on neurorehabilitation and how important it is in the NICU. But, you know, this whole time period up to the first year of life is really very critical. And so if you're not acting on what you are seeing from the early MRIs and doing that with good therapists, to me, that misses an opportunity. The only other thing at 1 year you have to realize too is the brain is in that very big transition point between being the watery baby brain and the more mature older brain. And it's actually really hard at around 8 to 12 months to see injury because there's not a lot of contrast. It's kind of like looking at a grey background with a grey outfit. I've got a grey outfit on a grey background and I can't have anything standing out anymore. When I had the watery, I had a white background and I could see things stand out more. And when I've got the mature brain at 2 or more, I've got a black background so I can see things standing out again. So that 1 year time period to me is a tricky time to do the MRI, but at 2 you can often see it. I personally also like 6 and 12 weeks. We've been doing more and more imaging around 6 and 12 weeks to see the full evolution of the impact of injury. And that's been very helpful as well. And we're hopefully going to, we're just starting another study on doing that. And I know as part of some of the research endeavours, I've strongly recommended us doing scans at 6 weeks to really see the full extent of either impact or outcome for our baby.
Yeah, that's really helpful. And so, you know, we definitely have, as you might see, like the chat is filling up with people asking additional questions about time points. And we do see some physicians that will ask for an MRI like outside of age 2, age 3, school age, you know, like, and is there, what would be some of the reasons why that might be? I mean, I've heard curiosity, like our own neurologist was like, yeah, I'd love to do one at age 2, but it's really just for my curiosity than something clinical. So if you could talk us through maybe some of the reasons why there'd be concerns for needing another MRI or just, you know.
Yeah, I think if there's not been the picture in the neonatal period that you understand. So if you really had two completely negative MRIs and then, the baby goes on and develops significant motor impairment, that doesn't make sense. If you've really got two completely negative MRIs, both an early and a later one, like somewhere around the first week, somewhere around after the second week, and they're both negative, and then the baby develops a significant motor impairment, I would be wanting to do another MRI to understand what is going on here. In the same way, I think sometimes it's more fascinating the other way, that people are like, wow, we really thought this baby would do so badly, but look how well they're doing. I want to see what's going on in there. And again, sometimes, we do know the brain can regrow actually now. And we're kind of always fascinated to say, well, could it have regrown? You can actually tell that by head circumference, because after 4 months of age, the head growth is entirely dependent upon brain growth. And so if the head is growing, then the brain is growing. So I think it's really only if again, there was something odd going on with head growth and the clinical picture and the early imaging that you might try to think, could there be some metabolic disease or some other vulnerability that I'm missing? Is this?
Oh, no. I think we're glitching just for a minute. Oh, there we go. And we're back. Yeah.
I apologize. I know the network is not completely stable here. Unfortunately, I'm in the NICU on service.
Thank you so much for that. That is just really helpful, I think, for our families to understand a little bit more of what that context might be. And then, like looking at now, we know so much more. I know that there's families that will have repeats, and then they're, the things aren't matching up. So then they're pushed more for like a genetic screening and rule out, and just again, trying to get as much information gathered on the baby or child as possible. Great.
That is correct.
Yeah. And you talked a little bit about, one of our questions was like, when it's not very clear, so like what happens when it doesn't match the outcome. But you really covered that in such depth. So I'm so appreciative that we got to that. And then I think when we talk about like moving into research and what, some of the things that MRI is being used for in research, you and I both got a chance to participate in a recent meeting, to talk about MRI potentially as what they call biomarkers, and something that could be used to show if something is effective or not, with this, very robust amount of therapeutic development that's going on that we're so thrilled about in HIE. And just if you could talk through a little bit about that. I know there's some people that are working on, like Pia Wintermark's working on the sildenafil trial, and her initial stuff was showing that there might be brain regrowth and, on the MRI. So I know this topic is going to come up a lot more with the research.
Yeah. So let me start by saying, MRI is good. I mean, when you look at its positive predictive value, it's better than a chest X-ray for pneumonia. This is the reality, that it is better than any other single biomarker we have. It's way better than, for instance, APGAR scores. It's way better than, for instance, blood gases. It's actually better even than the early neuro exam or EEG. So we know that, I hope you are still there, that the MRI is as prognostically powerful as we can get a tool to be, and that's why we suggest that it is useful as a biomarker. That would be the main rationale for us wanting to use it as a biomarker. In addition to that, what the challenge has been in clinical trials is that if we wait for developmental outcomes, we're not even sure that 2-year developmental outcomes are solid.
Got a little glitch, but we'll catch up in just a moment. There we go.
I'm so sorry, Betsy.
No, this happens. It happens. And we can also edit out the gaps, which is great.
Yeah. I was just saying that MR has the best positive predictive value for outcomes of any tool we know, better than APGARs, better than gases, better than exams. And that overall, that's why we like using it the most. Having said that, the other consideration is that, clinical trials, we have used 2-year outcomes at times, but 2-year outcomes aren't always stable either. And that if you look at the relationship between 2-year outcomes and 5-year outcomes, there can be big discrepancies because children can change between 2 and 5 quite a bit, actually. And so how long do we have to wait to know a therapy works? Is it 5 years? And we recruit for 5 years, wait 5 years? That would mean 15 to 20 years, maybe 30 years between when we would develop something and when it may get to actually help the baby. So that's why using something early to see if we have improvement in outcomes is what we have been enthusiastically trying to look for, and that's where MRI has been used in these research methods.
That's really, really helpful. And for our community that's paying attention and and is attending right now, that's part of the advocacy work that we're working and collaborating on with people like Dr. Inder and others, is how can we elevate our voices, because we know that the therapeutic pipeline is very long, and we need more effective interventions yesterday. So, there we go. And so I was just saying that, this is a part of the advocacy that we're doing, which is collaborating with people like yourselves and others in the space and elevating the need from our community of needing more effective therapeutics yesterday.
I apologize if people are on because I unfortunately don't have Betsy.
Oh no.
I know, I got you back.
Okay.
I'm so sorry too.
It's good. I was just saying that this is why we are involved in advocacy together, is to bring the lived experience and the voices. We know families need more effective therapeutics, and that we're trying to work hard. Everyone is forward to look at how we can accelerate this more.
And, what I would say too is that in these research studies, we are using very systematic ways of reading the MRI. It's not just somebody looking at the scan and giving you their report as it would be for a standard radiologist. We use a very research-based, very extensive tool, and it's read independently by blinded radiologists who know nothing about the clinical details. None of us are like that when we look at the scans. We know the babies, we know the background, and so we naturally have bias about things. That's not the way they're used in research. So it's a very systematic, very high quality way that it's applied.
That's really, really helpful. And so really, there's so much moving forward that is exciting with the research that's going on. And so, I think those are all the questions that we had. So the last thing that we always ask all of our guests, which is sharing what your favorite resources are, that you recommend to families, that you have, things that you're reading up on that you would like to share.
Yeah, what I would encourage families to do is ask to look at the MRIs, look at the pictures if you can. I know that's a big ask when it's your baby's brain. But it can, a picture's worth 1,000 words. It's like someone trying to describe a scene to you versus you actually looking at the picture yourself. It can be really helpful to have them, and I call it walking you through the images, because it really helps families to see what's actually going on in the brain, to be able to understand it. And then, the resources that, I am so grateful to Hope for HIE for everything that Betsy and her team have led, and that all of you as parents continue to do for each other, because I am always talking to my families about the resources that are on your site. And the enormous resources that you all have in each other, which is that your stories and I learn from every baby I see and every family that I'm fortunate to care for, because your experiences, your stories, your pathways, your journeys, they teach me and they challenge us, and they inform us about things that make us think differently. And so don't be afraid to share how things are different, and don't be afraid to tell us what's important, because we're listening, and you have incredible advocacy through this organisation, and we want to hear your voices, and we want to do a better job. And we know we have a lot of opportunity to do better. And so the more we can be guided as to how to translate this really complicated story, when we don't have all the answers all the time, but what we can do is at least be honest about what we know and what we don't know. And even when we know injury is pretty significant, we're never going to know 100% what the outcome's going to be, because every baby's going to be different, and we don't have the capacity to know how the reorganisation of the warehouse is going to go. What we do have the capacity to do is get some construction teams in there to help the baby to be able to try and reorganise. And what we do know is we have some ways, especially with Hope for HIE, to help the families, process the information that's been shared with them, and try to move forward in the best way they can, armed, ready, empowered, and supported, to be able to recover from the trauma of the neonatal experience, and to be able to feel like they're supported to know what, why, and how they can do their best as they navigate the next phase with their baby.
Amazing. Thank you so much for joining us today, and for obviously all the work that you have done and continue to do. It is, we see the efforts obviously, and, Max is going to be 13 next week. So seeing this landscape change significantly over that time is really inspiring and amazing, because, I don't know if it feels like that for everyone. It probably doesn't, who are just joining. But to see the amount of acceleration and research and understanding and improving clinical care, it really is amazing to experience that firsthand and reflect. So thank you so much for being such an integral part of that.
We have so much more to do. We have just started a study for ourselves on
never a shortage.
One of my junior faculty who's interested in sleep. And sleep following HIE, even in babies who have, imaging that is completely unremarkable. Why do they have so much difficulty for such a long, protracted period of time with sleep disorders? And we're going to try and investigate, what. And that came because she went to a session where she heard a lot of parents talking about the sleep disturbances that go on for such a long period of time. And she was like, no one seems to understand this. And is there something we could be understanding? And then is there something we could be doing to help? So your voices matter, and you matter. And so we will continue to try and listen and learn and move the field forward. But thank you, Betsy, despite the technical challenges, for hanging in there with me, coming and going. And I hope that at least some of the information got through and was useful today.
Oh, absolutely. We captured so much, and the next steps for this, for you to know and for our community to know, is this gets turned into a key takeaways blog and then social media squares. So the information is available in multiple formats for families afterwards. So they can, if they want to listen to this on replay or just read through the Cliff's Notes version, they can. And so this becomes an evergreen resource for us. So for those of you that have been tuning in, thank you so much. As always, always happy to hear your feedback of what we should cover next. And, we are so grateful for you, Dr. Inder. Thank you so much for joining us today.
Thank you so much for all you do. And thank you for the Awareness Month. And I hope as the years go by, we have many, many more positive things that we continue to work on together.
Absolutely. All right. Thanks, everyone.